Hello, thank you for joining us today. I'm Vanessa Ramirez and my co-presenters, Team Eagles, consisting of Karina Barrera, Angelina Camacho, Alejandra Garay, Justin Madrigal, and Kenya Torres, will be going over our analyzation of global poverty and health indicators. A quick overview of our presentation. We will be discussing the poverty statistics data sets. Please know, throughout our analyzation, the data sets are established by country-level information, which include birth rates, death rates, infant mortality, life expectancy, and per capita gross domestic product, GDP. Now, let's discuss some of the key factors of this presentation. We will explore how economic conditions relate to population health, understand global disparities using simple descriptive and statistical tools, as well as provide visual comparison of countries around the world. Let us begin with the hypotheses of our analytics. As a collective, we firmly assert that Region 1, specifically the country of Albania, will exhibit the highest birth rate, the elevated death rate, the greatest infant mortality, and the highest life expectancy, all while possessing the lowest gross national product, GNP.
So for our study design, we used a comparative descriptive study. We compared different countries using existing population level data. The data came from the dataset provided to us, which includes information on health and economic indicators for multiple countries. All countries in the dataset that had complete information were included for each variable. We compared each country across all variables and looked for patterns, especially how economic status relates to health outcomes. This design allowed us to observe differences between countries without running experiments or advanced statistics. Now for our study population, we included the national populations of all the countries in our dataset. We're not looking at the individual people. The dataset is summarized at the country level. Each country represents millions of people, and we included all countries that had complete data for the variables we analyzed. Countries with missing values, like missing GNP data, were excluded. Overall, the study population represents a wide range of regions and economic levels. For this project, we analyzed several key variables. We looked at the birth rate and death rate for each country, which tells us how many people are being born and how many are dying per 1,000 people. We also examined the infant mortality rate, which shows how many infants die before age 1. Next, we looked at male and female life expectancy, which tells us how long people are expected to live on average. Finally, we included GDP per capita, which is a measure of how economically developed each country is. Together, these variables help us compare health and economic conditions between countries.
On this slide, I'll be talking about statistical methods. For this study, I based on descriptive statistics to compare countries on birth rates, death rates, infant mortality, life expectancy, and GDP per capita. I also cleaned the database by removing countries with missing and invalid values. The comparison between countries and regions were shown through simple tables and bar charts. No inferential tests were used here. The goal was to simply describe the patterns in the data, not to make predictions. I'll be moving on now to descriptive results. The results showed clear differences across countries. Lower income regions generally had higher birth and death rates, as well as higher infant mortality. Higher income countries tended to have longer expectancy and better overall health outcomes. Across all variables, we saw the same pattern. Countries with higher GDP per capita and typically showed stronger health indicators.
Region classification. The data was organized into 6 regions. Countries were classified by a mix of both geographical proximity and levels of overall wealth and development. Region 1, Eastern Europe, contained countries such as Bulgaria, Poland, and Romania. Region 2, South America and Mexico. Region 3, Western Europe, including countries such as United Kingdom, Italy, Germany, and France, alongside the US, Canada, Australia, New Zealand, and Japan. Region 4, the Middle East. Region 5, Asia, and Region 6, Africa. This is a key graph based on the previously mentioned variables. The data represents the yearly average per 1,000 people within the regional population during the year 1990. This means that the data was gathered from a population at one point in time to describe the characteristics of the population. This is otherwise known as a cross-sectional study. Another thing to keep in mind is that none of the regions had an equal amount of countries, which are representative in the data. Taking a look at the table, the most interesting category to keep an eye on is GDP, or Gross Domestic Product. Out of all the regions, regions 3 and 4 had a significantly higher GDP. The following bar graphs provide a clear visual of the differences of variables across each region. The first two bar graphs compare average live birth rate per 1,000 people and average infant deaths per 1,000 people, with infants being classified as under a year old. Region 6 experienced higher live birth rates but also higher infant deaths, while Region 3 had the lowest live birth rates and lowest infant deaths. The other regions fit in between these two levels. These next bar graphs illustrate the relationships between average life expectancy and average death rate. While life expectancy appears to be the same for the most part, again, Region 3 had the highest life expectancy between 71 to 78 years old, while Region 6 had lower life expectancies between 51 to 54 years old. This is for both male and females. While the average death rate showcases Region 6 as being significantly higher than the rest of the other regions. Lastly, this bar graph is the most telling, as it showcases the average gross domestic product per capita, calculated in USD dollars. Here you can really see how regions 3 and 4 have significantly higher GDPs compared to the other two regions. This factor may offer some explanations for the other values calculated in this study.
Strong correlation. There's a strong positive correlation between a country's level of economic development, often measured by GDP per capita, and its overall population health outcomes, measured by indicators like life expectancy, infant mortality, etc. Economic development is key to health. Higher levels of economic development generally provide the resources necessary to invest in robust public health infrastructure, like sanitation or clean water, fund accessible high-quality healthcare systems, support higher levels of education, which lead to better personal health decisions, improve nutritional standards across the population. Income inequality and health challenges. Lower income countries, LICs, face significantly greater health challenges. These include a higher burden of infectious diseases like malaria or tuberculosis, higher rates of child and maternal mortality, limited access to essential medicines and specialized medical care. Limitations of the study. The limitations that have been provided are crucial for properly interpreting the findings and making appropriate policy recommendations. Here's a summary and discussion of how each limitation affects the conclusions drawn from the study. Data from the 1990 is time sensitivity. The data is over 3 decades old. Conditions in many countries, especially rapidly developing economies and those affected by major conflicts or health crises like the AIDS epidemic in the 1990s, may have changed dramatically. Countries like South Korea, China, and India have seen massive economic and health improvements, making 1990 data unrepresentative of their current health status. Countries experiencing prolonged conflict, political instability, or the resurgence of certain diseases may show worse outcomes now than in 1990. The findings establish a historical relationship but may not accurately reflect the current state of global health and economic development. Missing or incomplete data. Some countries were excluded or have incomplete health or economic matrix. This introduces selection bias. Often the countries with the most incomplete data are the least developed or most unstable nations. Excluding them means the analysis might underestimate the severity of the health economic challenge faced by the most vulnerable populations. The relationship might be even stronger, more challenging for LICs than the current data set suggests. Missing key variables. Incomplete picture. The issue is the analysis does not include variables such as education level, actual healthcare access, such as number for doctors per 1,000 people, or public health spending. While GDP per capita is a good proximity, it is not the actual mechanism of change. The analysis lacks explanatory power regarding why some countries are outliers. A country might have high GDP due to oil but poor health because they do not invest that wealth in education or primary care. A country with low GDP but excellent female education might have better health outcomes. Takeaway: the model describes what is happening, correlation, but does not fully explain the how, causation through policy and investment. Cross-sectional design, no causation. A cross-sectional design captures data at a single point in time, 1990. We can establish a correlation. Economic development is linked to health, but cannot establish a causation. Does wealth cause health improvements, or does a healthier, more productive population cause wealth? A longitudinal study tracking countries over time would be necessary to understand the dynamic relationships and their direction of influence. We must be cautious about concluding that simply increasing GDP will automatically improve health. The relationship is likely bidirectional and complex.
In conclusion, Albania's high rates of poverty can be attributed to a combination of factors: the high birth rates, low death rates contributing to population growth, high infant mortality reflecting inadequate healthcare, and the lowest gross national product, GNP, indicating limited economic productivity and overall wealth, are a big factor. These elements are some challenges in Albania's socioeconomic situation. Future research. For future studies, it should use current comprehensive data, including often omitted nations, to avoid biases. Key variables like education and healthcare access should be added to better explain health outcomes. Longitudinal designs are needed to show causation, not just correlation, between economic factors and wealth. Additionally, case studies of developing countries and advanced statistics can better our understanding, ultimately helping reduce health disparities.